Well, hi, everybody. Welcome to today's live webinar hosted by Roji Health Intelligence. My name is Garrett Schmidt. I'm the managing editor and CEO of VBC Exhibit Hall, and I'm glad you have joined us today. Our session today is called Create Successful Pathways for Primary and Specialty Physicians in Value-Based Care, and or how to create rather. And very excited about this session. I got a little bit of a preview when we went through it a couple days ago, and I think you guys are really going to enjoy the subject matter today. There's a lot there, so listen closely, but don't worry, we're going to send out a recording after the fact to everyone that's registered. There'll be a link to where you can watch the recording again and download the slides, and you'll have all that information there for you. A few items of note before we get started, and then I'll introduce our speakers today. Everyone has joined today in listen-only mode. This is a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera or anything like that. Don't worry, we can't see or hear you, but we do want to hear from you, and so we're going to have a time for some Q&A towards the end. And if you have a question for our speakers at any point during the presentation, go ahead and drop that question into the question module. There's a little area on your attendee module for questions specifically, which is different than the chat. So go ahead and use that for your questions, and we're going to get to as many as we can. If for some reason we're not able to get to yours today, if we run out of time or whatnot, don't worry, someone will reach out and answer your question for you through email. So go ahead and drop that question in again at any time. And then finally, again, the session today is being recorded, so afterwards you'll receive a link to the recording and to where you can download the slides. All right, without further ado, I wanted to introduce our speaker today. We have Miss Terry Hush, and she is the CEO and founder of Roji Health Intelligence. And we also have Dave Halpert, and he is the Chief of Client Team, and he's going to be stepping in mainly towards the Q&A at the end to help us with that. So at this point, I would like to turn it over to you, Terry. Welcome.
Thank you very much, Garrett, and hi, everybody. I'm delighted to be here on this topic in particular because I find it fascinating what's going on with the direct physician value-based care component. I want to apologize in advance for the raspiness of my voice, and hopefully it won't be a problem. I have an end of allergy season asthma thing going on, so I might be drinking a lot of water, and hopefully I can get through it happily. So let's get started. There's a lot of content here. First, my little infomercial about what we do and why we're even talking about this space. We do provide value-based care technology and services to providers, and we help them participate in models like those that we are going to be talking about today. We are also an ONC certified registry for quality reporting for both the MIPS and APP reporting for ACOs. And we have developed episodes of care to focus on the cost component and helpful in a lot of these models that are now focused on addressing the total cost of care. Okay. So the first thing I want to do is ask you some questions so that I have an idea of where I'm meeting you on your journey of the provider-focused value-based care initiatives. And the question I have relates to what is the best tool for engaging physicians in value-based care initiatives? And we'll address some of these issues throughout the discussion today. But do you think that the best tool, so you get to choose one here, is data sharing, financial incentives, or appealing to the mission and professional goals? And I'll give Garrett a little bit of time to do that survey.
Yeah, we got the survey is up, and so you should see that on your screen right now. We do have the results are pouring in here, so we'll give it another minute or so for the results to come in. And again, this is a choose one that most applies. I know some of you are thinking, or all of you are thinking, well, all of these things are, but if you had to pick one that was most effective, that's what we're going for here. Data sharing, financial incentives, or mission and professional goals. So we're going to give it about 10 more seconds, excuse me, and then we'll wrap up here.
I know it's hard. And
Okay, I think,
everybody's in a voting frame of mind right now.
yeah, this is true. So, okay, we're going to go ahead and shut it down in five, four, three, two, and one, and I'm going to share the results here. Okay, so I know Terry, you may not be able to see the results, so I'll read them to you. We had for data sharing, it was 27%, financial incentives, 65%, and then the mission
Wow,
professional goals is 8%.
very interesting. That's very interesting. Okay, I'm going to address my thoughts on some of these things as we go forward. So thank you for participating in that survey. So today's focus, as you can tell from the title, is direct efforts aimed at physicians. And we're going to look at CMS strategies. What does an accountable care relationship really mean at this point? The newest models that are aimed at physicians, how do these affect existing models that are aimed at groups like ACOs? And then how health plans, ACOs, and professional groups can prepare for all these models. So here's where I want to start. CMS has had a dilemma that we've been looking at for several years when they established a 2030 target of 100% of beneficiaries in accountable relationships. And the reason that's a dilemma is because ACOs aren't growing fast enough to meet that. And 40 to 60% of physicians and no more are estimated to be in ACOs. So you don't really have the numbers supporting the goal at that point. ACOs also vary widely on achieving savings, and so that's an issue for CMS to meet the target. All of the transitions to value-based payment models have been slow, with the majority of physicians still on fee-for-service. And in fact, what some of the models are showing is that the innovation center models have actually increased spending rather than decreased spending. So the strategy needs to be adjusted at this point, and I think that's what we're seeing. On the physician attitudes towards value-based care, we see more primaries that are participating in at least one payment model. So almost 60% of primaries are participating in one, and about a third or a little over a third in more than one in 2022, according to one survey. And 60% of primaries and 40% of specialists participate in these. On study two, however, we see a slightly lower number of primaries reporting any value-based payment, which means of that 60% of primaries that are participating, most of them are on a low-risk track. And smaller independent practices that serve about 40% of Medicare are the least likely to participate in any of these payment models. So that's kind of the space that we're operating in to see what can happen with physician focused. So here we have a fractured physician. This is Paul Clay, the physician, and I think it's a perfect image to describe the kind of scenario that physicians find themselves in right now. But why are the efforts moving in this direction? It's because, as we just saw, the participation is low. There's also a shortage of primary care and specialists coming into play here, so it's hard to make up for the low participation because there's not a lot of physicians out there who can participate in these models. There's a need to rationalize the care through all of these different primary and specialty practices and facility settings. Primary care is perceived by CMS to be central to better and lower cost of care, yet the fragmentation has continued and the costs still aren't going down. So the solution that they're coming up with is practice involvement in costs, practice involvement in defragmenting care. It's a messy geography. If you're a Tolkien fan, uh, Mordor is off here to the side and it remains a threat, but there's an overlapping of all of the different payment models, all of the different solutions to address costs and quality throughout these different payment models. Water break. So the new initiatives, rather than adjusting the existing payment models, completely hop over them and target cohorts of clinicians. Primary care models, I'm using a primary color theme here to look at those, support primary care physicians in practice transformation for value. And that's a new part of all of these different payment models. And there are several active ones right now. What we're going to focus on today are primary care first, making care primary, and ACO primary care flex, which even though is an ACO model, I'll explain why I think that's much more of a physician model than, say, some of the standard MSSP ACO models. There are other accountable care models with an emphasis on primary care like MSSP, ACO REACH, the Maryland Total Cost of Care model, Pennsylvania Rural Health model, Vermont All Payer model, which are all CMS innovation models, yet none of them have the kind of direct impact on physician practices that you see with these things that we'll be discussing today. The primary care models have some features that are in common and some that are distinct. On the common side, we're looking at payment for advanced practice management functions. We are looking at financial risk. That is definitely on the increase in these payment models and has become a pretty strong feature of all the new payment models that CMS is bringing out, and moving towards capitated payments on the primary side. There are also differences between all of these models. One is which population they deal with. Another is what the underlying payment structure is in moving towards capitated models. What's the scope that they're trying to accomplish? And the inclusion of other payers besides Medicare, which is also an important facet of these direct physician models. All of the new models, this is a really important point, all of the new models are trying to correct for under-resourced primary care, but they're also pushing for risk. And the reason this is happening is because the perception is that many of the other payment models are not reaching their pinnacle of success because we have not addressed the underlying issue of under-resourced primary care, and that there isn't enough money in the system to actually change it. So let's look at the payment models themselves and see how that stacks up. First, there's primary care first. Now, this is an existing payment model. It's now in its fourth year, and its purpose is to lift up primary care. So why the image that I think is relevant to this. Oops, sorry, I just flown by one of them. As I said, primary care first is in its fourth year. It was a 5-year model, so we're going towards the end of that. It is prospective, risk-adjusted, population-based payment plus a flat visit fee. Hard to say in one go. It is exclusively focused on practices that are experienced in care management. So what they did was take a subset of practices they thought could be very successful and try to change the economics of primary care and see what happened. They all needed to have certified systems. They all needed to be able to do longitudinal care management, or were doing longitudinal care management. There's a behavioral health integration approach to this, and they are measured on outcomes, patient continuity, patient experience. So what do we know about it? Well, the most recent evaluation, it's a little old, is from year 2. The primary care first payments were higher than fee-for-service. I guess that's probably because more money went into it. But on the real downside is the reason they're higher is because in the last bullet, they didn't have enough to support transformation, but they also had no effect on hospitalizations and Medicare expenditures. So was it really an issue of not being enough, or was there something about the model itself that didn't really come to fruition? And therefore, we see the next model emerging on the basis of primary care first and its successor, CPC, and that is making care primary. So build a new city, CMS says. Build a really good city that has the pinnacle in it. The key features of making care primary is that it allows a longer time for practice transformation to occur. So it's 10 and a half years beginning this past month. There are 772 practices, 8 states, voluntary model, had to apply. It has a component of advanced primary care in it, meaning they're doing specific care management functions. And there's a gradual movement into value-based payments. And that gradual movement is a 3-track approach that starts with the building infrastructure where payment is fee-for-service. And so practices, because these were not experienced practices, these are anybody who has the ability to participate in this model or willingness to participate. So the first thing is to build infrastructure so that they can population health, look at data, make sure their systems are aligned, the data is going into a database, they can harvest that, do analytics and so on. That is a fee-for-service kind of first year is getting ready. Second year is advanced care management. There's a payment on a per capita per month basis for that, and it allows them to add revenue for actually doing some more services in the practice. And phase 3, optimize care and build partnerships. It could be with community organizations. There are a variety of different partnership functions that are alive in a primary care management scenario, with specialists, with community organizations, with other kinds of organizations, behavioral health, and so on. So they can adopt a lot of the models that were in the primary care first program, but it is up to the individual organization to be able to select those models. So we don't know, of course, how they're doing yet because they're just getting started. And we're in the business of helping our clients who are participating in this model build that kind of infrastructure where they can see how they're doing and where they can organize their patients by risk to be able to build the infrastructure and do care management. The third model is ACO Primary Care Flex. So it is an ACO model. It is within the MSSP population of ACOs, but it is directed. And what it is directed to are those ACOs that are low volume and low revenue ACOs. And they tend to be the core of physician-based ACOs, which CMS has considered the most important driver of savings in the entire MSSP program. But what they're doing for this is they know that those are particularly under-resourced groups of practices in those ACOs. And they recognize that they need money if they're going to transform into becoming data-driven and really focused on even producing more savings. So it introduces a capitated predictive payment model into this core of ACOs. And the other thing it does, which is really interesting, is add other payers. So a lot of these ACOs are only Medicare ACOs. Some may contract with other entities, but this allows them to participate in a broader based method of care management that affects more patients as well. And it could be that those other payers that are involved are willing to participate in these additional payments too. So the features, we don't know how many are going to be participating because the actual application deadline is coming up shortly. There are though 130 low revenue MSSP ACOs. And so we'll see whether it's a successfully marketed model to that group. It will be a 5-year model beginning in January of 2025. Its explicit goal is to reduce costs while improving outcomes. And then the economic part of it, the value-based payment part of it, is a prospective primary care payment. So it's not a global cap, but it pays the primary for what they perceive the primary's role or the practice role to be in generating these savings. So that covers some physicians. It doesn't cover probably a real lot of physicians who are not participating in value-based care. But here's an interesting new piece of the new physician fee schedule quality payment program rule that came out in July. That rule provides advanced primary care management fees for primary care physicians if they have aligned patients with chronic disease. They are automatically considered to have accountable relationships. In particular, if they have an actual alignment with that patient that is documented or relevant. Both ACOs and non-ACO providers meet the criteria and are included in the program. And we'll see whether this rule gets finalized or not, but it's, I think, a really important redefinition of how CMS is folding in what they perceive the role of accountable care to be in the entire traditional Medicare population, and how they will also meet the numbers that they have in their strategic plan. So let me do a brief takeaway on all the primary care models. All of them recognize the financial challenges that practices have faced in becoming part of value-based care models. There's a consistent movement towards capitation and risk. There's a financing of the infrastructure. They're really pushing the certified health systems and the interoperability of data and data sharing. There are explicit goals of quality, cost, and health equity throughout all of these payment models. And then, as I mentioned, there's a new twist to incorporate physicians that are not officially in any payment model at all, kind of an annexation of physicians in primary care, value-based care. Now I want to start moving towards the specialists. But there's another thing that has come up in all of the literature from CMS that I think we need to focus on now. And we'll get at the heart of this in one of the specialty payment models, and that is the primary specialty collaboration. So for a long time, in every single of the rules governing the quality payment program and governing the physician fees, CMS has asked for input on how to control the costs of or manage the costs of specialty care. And they are starting to come up with some strategies that have some goals in that regard. Supporting person-centered, and their idea of person-centered means that regardless of where a person goes, you have coordination of care for that person. Value-based specialty care is coming online right now. They want data on specialty performance. They want episode payments, integration of specialists in primary care pathways, and creating incentives for ACOs to manage specialty care. Those are all features of the strategy that we're going to be seeing in a lot of different primary and specialty payment models, and probably some that are aimed at ACOs. So let's take a look at active specialty models. This is a picture of, it looks like Andy Warhol actually, but I don't believe it is. And specialists are beleaguered right now with a lot of different, a high volume of patients, a shortage in virtually every specialty, a lot of different efforts towards managing their costs, and where to go in terms of how they respond to the models out there so far that have been focused predominantly on primary care. The active specialty models that we're going to talk about today are the single specialty focused payment models, which are very elaborate, have a lot of data behind them. They are focused and require application by individual practices or organizations. And those are the Enhancing Oncology Care Model and Kidney Care Choices. Then there's the bundled payments for care improvements. I want to mention that even though that program is being phased out, because it's an important initiative that where there's still some bundled payment models, clinical areas that are not yet addressed in going forward in some of the later payment models. Then there's cost measures. Cost measures, there are 28 of them, or maybe more at this point for 2025, that address a market basket mix focused entirely on cost, not so much on the quality through the cost measures. And then transforming episode accountability model, otherwise I'll always refer to it as team, so we don't have to say all those, that was just announced this month. And that is a very interesting initiative that we'll see on the specialty side. The focus of all the specialty models is not so much transformation as it is reduce costs and optimize and coordinate care. So let's take a look first at the Enhancing Oncology Care Model, which they refer to as the Moonshot Initiative. The key features of that program are a two-part cohort, one that started in 2023, one that started in 2024, 41 practices in the first part, and the focus is on chemotherapy episodes. There is financial risk as part of the program. So what's new about it? Well, the first thing that's new is a specialty-focused and episode-based payment model that requires coordination of patient needs beyond cancer treatment, not just cancer treatment. Patient practices get claims data, So that's good. It helps them see what the actual cost of their episodes are and determine what is driving cost. The practices are at financial risk with an episode-based payment in these. And there are many features of this. It's extremely complex. We are organizing right now um, the technology for one of the participants in this model and are working with others who are planning that kind of technology structure as well to focus on how to use the episodes in a way that is actually going to give them the data they need to lower the cost of care and to recognize what's going on. The CMS episodes are a time-based bucket. They are not delineated by, let's say, a complete episode and what happened to the patient. So practices need to understand, are there admissions in ER utilization caused by comorbidities, or are they caused by the effects of chemotherapy? Very different distinction. And so one is within their control, the other one requires coordination with primaries. The goals of the Enhancing Oncology model are to transform and improve care coordination. So a lot of that is dealing with other risks that the patient has and making sure that they're in connection with the additional specialists or the additional primary care physician that the patient has, but that they also understand and deal with the environment of the patient and being able to access and respond to care. And that means screening for SDOH, coordinating patient needs in the community, providing support for the patient when they need it, understanding what that patient care plan is, communicating that to the patient along with the evidence-based reasons for that care, creating a financial structure for each 6-month episode that CMS pays on, ensuring accountability within that total cost of care for chemo and all of the other costs related to that episode, and distributing that among the physicians who are involved. Very, very complicated. But I think that this is representative of the model we are likely to see for a lot of the condition-based episodes of care specialty models going forward, many of which were in the BPCI program, or BIPSI, as some people call it, and that includes, for example, AFib is in there, or other cardiac conditions which may result in an intervention, a surgical intervention, but may not. And so those are a model that is that this is really testing on behalf of all of the different kinds of specialty-based models that can be brought out in the future for value-based care. Broad reach, 41 practices, but look at the distribution of this. They're all in all of the major centers of population in the country. So let's move on to the kidney care choices model. Similar kind of model, but I would say less complicated. There's 103 physicians that began 2 years ago, 2.5 years ago. And there are patient episodes just like you have in chemotherapy, but they are for chronic kidney disease or end-stage renal disease. And it doesn't include an only risk option. It includes both non-risk and risk options, depending on the inclusion of dialysis and whether you're dealing with chronic kidney disease or end-stage renal disease. The purpose here is actually preventive. The goals are to delay the onset of dialysis for patients in chronic kidney disease, stage 4 and 5, and end-stage renal disease, and move transplantation up in time so that patients can do better. So it transforms the care through the kidney care team, including nephrologists, dialysis centers, and others in the patient care team, which is an important feature. Its goal is to reduce patients with kidney failure in dialysis centers and increase the transplants. And there are 4 options with graduated risk. So let's move on to team. So what's new about this? This is the transform episode accountability model. That's what I said I would never say again. This is also a first. It's a first episode-based mandatory specialty payment model. So all the others have been voluntary and practices can join or not. But this is mandatory for 5 procedure types or clinical areas: the lower extremity joint replacement, spinal fusion, surgical hip femur fracture treatment, cabbages, and major bowels. CMS says that they selected this because these are all voluntary, but maybe voluntary is a little bit of an overstatement with some of these. It's a 5-year mandatory model in certain selected areas. Again, high population CBSAs, we used to call them SMSAs. Hospitals must also participate. In fact, here's what's interesting about both BIPSI and TEAM. It's the hospitals who convene these episodes. So while they are directed at hospital costs and physician costs, the physician is actually the actor in here, but is not the convener of the episode. So it's kind of an interesting mix of how this might work in terms of the physician perspective and their control over the model here, and also the communication, because it does require a lot of information sharing and coordination between the primary care and the specialist who's doing the episode treatment. There's 3 risk tracks. It's a glide path: 0 risk for the first year, and up to 3 years for the safety net hospitals, which are in these highly populated areas. There's lower levels of risk for safety net and rural hospitals in track 2, and then it moves into an episode. A lot of details on that. I would take a look at that. It's likely to be the model that comes out for payment of specialists across all of the other BIPSI procedures and potentially some of the procedures included in the 28 cost measures that CMS has defined. So let's look at the path that all physicians really need to focus on for success in these models, because unlike the ACO models, they don't necessarily have the infrastructure, the data, the organizational elements of being able to be successful unless they use a real path to success. So the first step in that process is to review the EHR system and see if it will actually provide the mechanism to support analytics and episodes of care. That happens as step 3. It has to be aggregated out of EHR systems into an analytics vehicle for the creation of those episodes to care, so that physicians can see where they are with their current episodes. It's a, a mind-bending experience to look at data through episodes of care surgically or condition-wise, I can tell you, because this is one of our standard analytics for looking at procedures and for chronic illness. And these really show some of the drivers of cost and of outcomes in these models. And so it's a step that is not included in the way that CMS organizes the data. The episodes, according to CMS, are much more cost driven. They're not clinically focused because the claims data does not have clinical information in it except for the procedure codes and the diagnosis codes. But when you are harvesting the information from the EHR system, in addition to claims, you have the capacity to put those two together and see what's happening with the patient and what happened to drive the cost up or what happened where the cost was lower. Once you do that, though, the most important aspect that physicians need to appreciate is how that data gets shared with physicians. And the next best thing that comes out of that is the feedback from those physicians and refinements to the episode itself or to the understanding of where they fell on the spectrum of cost variation or improvements. Only then can you actually start a series of clinically based or clinically pathway based improvements in intervention. So all of this depends on having the data organized into episodes, sharing it with physicians, providing feedback loops and the ability for physicians to look at snippets of data that doesn't overwhelm them, not scoring them, participating in a learning and collaborative environment so that you can have interventions at the end that actually meet the goal. It's a long path, but it's the kind of thing that needs to happen if physicians are going to be successfully participating and care is going to improve. So the biggest challenges to that pathway is the availability of data, attitudes about data sharing, accountability beyond the scope. So let's take a look at the accountability beyond in the enhancing oncology model. The practice must initiate the relationships with outside entities in order to have services delivered to cancer patients that are beyond the scope of chemo episodes and their clinical care. Physicians who are in ACOs or in primary care practices must have a mechanism to share data with their specialists so that that care can be coordinated. These are not easy things. They sound easy on a four-bulleted list, but these are beyond what any of the realities, with the exception of maybe a very integrated health system, is doing right now. Making those episodes so that they can be clinically understood by the physician, not on a cost basis, not with a mixed bag of various procedures, but focused on only the clinical things that happen in that episode of care. And then trying to deal with the primary care boundaries. I think it's a tall order. But you can't play without that team, and you can't play without a ball. The physicians need to see the results. Everybody who's organizing and practices and wants to participate in payment models needs to address how physicians see results. Some practices believe that they're trying to help keep the physician focused on patient care and that they don't need to see all these things. They do. ACOs are just beginning a data journey of their own. They have only had claims data in most cases. They're just beginning to get clinical data, and it's very sparse because many ACOs are getting that clinical data from their practices, and the practices don't have the ability to give it to them. Private groups often don't see performance data either. So there's a cultural shift that has to occur in including here. Okay, I'm just going to flash this up because you can see it later on all the different data that needs to be available to pursue costs. Accountability is another thing I want to mention in the payment models. You have to watch for the add-ons to your scope. So if you are in a payment model that is organized by where the convener is a hospital, that is going to make a difference to how you perform on that payment model. So there needs to be an agreement with every physician who's operating in a facility what the path is. And primary cares will need to develop referral and cost arrangements for those specialists. I don't see it too far in the future where ACOs will be negotiating costs with specialists. That will be some leverage that they have. Would not be surprised. Either that or CMS will come up with episode-based payments for virtually everything, and I think that's too much. All groups are going to need to build partnerships beyond their scope. Primaries for community organizations and specialists with hospitals, surgical centers, diagnostic centers, all the things that affect their episodes. So, quick wrap up, 4 themes. Love this owl. First, no doubt about it, CMS is going to reach its numbers for accountable care, and they're going to do it by making sure that the entire traditional Medicare includes accountable care, and they will pay for it. The money from that will come from the primary care management fees, and they will be taken from episodes of care. So I think we'll see a flow of the payment system away from specialty care, or an attempt to flow that system away from specialty care and into primary care. Both primary care and specialists will have to be the focus of multiple payment models for this to happen. And although a few years ago, CMS told us that there was going to be a hiatus of payment models, I think they're coming fast and furious at this point, and I predict that will continue happening. The future payments for primaries will be population-based in many cases, for specialists, episode-based payments. Physician groups have to build the performance structure and the performance data they need to deal with this. And now I have questions. I made it through without coughing.
All right. Yeah, congratulations. I know you were you were worried about that. So, all right. So we do have some time for some audience questions. So if you have a question that you would like to ask Terry, um, please drop that question into there's a little module there that has a place for questions. And we're going to get to as many of them as we can here if the time allows. So in no particular order, I'm going to ask this one first. How will these models address primary care physician burnout, or simply abandoning their practice due to frustration and dissatisfaction?
Well, I think burnout was one of the key reasons for supporting all of these initiatives towards primary care. The transformation model that CMS is pursuing is one of a clinical care team that is run by the physician. And you see this model pop up in a lot of cases, but it's all about a team approach with the physician leading the clinical team, but supported by population health and a variety of people, and care being much more organized and proactive. That's the way they hope to address burnout. I think the other issue, and they can't answer for the shortage issue, at least at this point. I think we'll see that down the line, but not now. And shortage is also driving some of the burnout. But moving away from volume and moving towards a capitated environment takes the incentive in a different direction than primaries having to work ridiculous hours to be able to do what they need to do to generate the volume and the revenue for the practice. Moving it on to a different economic basis is helpful in that regard. It's not the only answer, but that's what they're pursuing.
Okay, great. Next question here is how will the CMS, and this is a two-parter by the way, how will the CMS Innovation Center strategy to integrate specialists in primary care pathways work? And the second part of that question is since CMS obviously can't monitor the relationships between primaries and specialists, how do you see ideas materialize in value-based care payment models?
I think this is going to be the most complicated situation ever, but there will need to be some kind of um, evidence that there's a primary involved in aftercare. Now, the way they structure the episodes will make a big difference in the future. And it could be that CMS requires that all participants have shared episode data, for example. I expect that they will. They will require that a common feature of primary specialty collaboration model will have shared data, referrals back to primaries, and it makes sense because the specialists are so overloaded and there are so many long waits right now for with patients that could be seen in the primary care setting to continue the treatment that's developed according to a plan by the specialist. So I think that's the issue. The issue is that the patient is not being returned back to the primary. That's one of the issues. Not for a proceduralist, but definitely for in the case of, let's say, a medical specialty. And they will try to address that. And we see hints of that in some of the models. We see a lot of that in team where they're requiring a referral. I don't know how they're going to get that data, but maybe they'll be using claims to identify. I have no idea. It'll be, there's still a lot to do on how these models are detailed out.
Yeah, great, great answer. Next question here is how are specialty care models different from these primary care models, primary care focused models like primary care first, making care primary, ACO, primary care flex? And do you think CMS will add more single specialty models or will the strategy focus on mandatory episode payments?
But I don't think that last two are exclusive. Um, Single specialty models with episode payments are pretty much the same thing. And I do think that we will see care models that are focused on single initiative or single type of patient. We may be like, let's take metabolic disease. It would be an interesting primary care model that would involve specialists to have a program aimed, just like the enhancing oncology model, on diabetes and hypertension, obesity, variety of outcomes between a primary care group and a specialty endocrinology group or a cardiac group. Those are things that, it's hard to break up without, you can't get too messy. You can't break up the entire medical establishment. But I think that those are the issues that people are trying to grapple with right now. What fits in what kind of model best to have the maximum impact on patients and the maximum impact on costs? But the specialty models will be driven by cost and coordination. The primary care models will be driven by supporting those primaries because it's a big job to manage all of the care of an individual and deal with their social needs too.
Yeah, great. We have a couple more, we have a few more minutes for a couple questions. Can you briefly describe the 23 cost measures? Or is
Um,
that a brief question?
it's not really a brief question. The, there are a lot. There were 28. Now I think there's more. I can't remember how many the latest version is. They are everything, but they're a basket, let's say. Every one of them is a clinical area that includes a number of different procedures and patient types. So what is the average cost of AFib? What is the average cost of patients with an acute myocardial infarction? Those are two different cost measures. There are others, and they take all the expenses. They figure them out by acuity and by risk of the patient, and they say this is what they should be. And the groups that exceed those expenditure volumes have a disincentive attached to them, have penalties attached in their programs. So they don't have the groups do not have the detailed data to really evaluate the CMS arithmetic on all of those things. And they also have no appeal mechanism for it either. They can't say, but my patients are sicker. You can't do
Yeah.
that. Um, so it's a MEDAX approach on cost that is not necessarily it's not where the payment models are going, but it does define the areas that CMS believes there is enough cost variation in to have measures that say, okay, we're going to have a usual and customary here. And if your patients don't fit it, well, then, you better make sure that they do. Because since physicians are responsible for all of the care that are associated with patients, regardless of, their actual care, then that works for them, right?
Yeah. Great. So we have time for one last question, and hopefully it'll be a brief answer, and then unfortunately we're going to have to wrap up. By the way, if you did submit a question, we do have a number that came in that we won't be able to get to. Don't worry, someone will be able to reach out to you and answer that question via email later. So if you have a question, even as we're wrapping up, go ahead and ask it, and we'll get to it. So this last question here is, how will this impact physician compensation, and particularly the discrepancy between cognitive and procedure work? Are we building a value-based comp model on the backbone of fee-for-service models?
That's an interesting question. Um, Cognitive versus procedural. A lot can fall in the category of what a cognitive um, physician service is, what physicians do to actually evaluate the case and so on. Like, I think that what we have is a fee for service model and it is being used as the backbone, no question, in specialties. We're not reinventing the wheel at all. So all of the cost models, not so much the fee for service on the primary care side, but it is still based on the RVUs. RVUs are the common theme. How much resources went in to this payment? And that was how the differentiation between primary and specialty fees originated. So that is not gone. It is partially baked in with some adjustments. And it is taken down to a capitated or patient level or episode level, and then kind of debundled into a per patient or per episode payment. So that is true. But throughout that, there have been some adjustments. They're definitely not making it up from scratch.
Wonderful. Well, thank you. I know I'm sure there's a lot more you could say. Unfortunately, we are out of time. So I wanted to thank you all for coming. Again, if you have a question, go ahead and drop it in. Someone will get back to you. But that's all the time we have for today. Terry, thank you so much for a wonderful presentation. And your voice held out, so we didn't have to have Dave come in and to the rescue after all. So grateful for that. As we wrap up, wanted to encourage you all to head over to vbcexhibithall.com and check out the Roji Health Intelligence virtual exhibit booth, which you'll see on your screen here. There's a lot of great resources there you can read up on, and there's a link in these slides. It'll take you right there. And you can read up on what they're doing, educate yourself on them. They'll be happy to help you in a variety of different areas if need be. And also on BBC Exhibit Hall, there's a lot of great resources on all kind of different needs that you may have in an educational sense or a solution sense. So feel free to reach out to me or head over there and just take a look around if you'd like. And then finally, if you would like to reach out to Terry directly, feel free to do so. Her email is right here yeah, her email is right here. And so is Leonard's. And Leonard, well, you haven't met today, but he'll be able to help you out as well. So feel free to reach out to either of them and they'll put you in touch with who you need to be, and or I will be happy to facilitate an introduction if you'd like to just reach out to me. That's fine. But thank you all so much again for spending your afternoon with us. Thank you, Terry. Hope you all have a wonderful rest of your day and join us on the next one. Bye bye,
Thank
everybody.
you, everybody.